Please welcome two world-class leaders of two world-class healthcare institutions, President of UT Health Northeast, Dr. Kirk Calhoun, and President of UTMB, Dr. David Callender. Good to see you. David, good to see you. We first met about this time last year when I was at UTMB filming a documentary that I'm working on neuroscience and featuring some of the great work going on down there, focused on Alzheimer's and CTE. I'm the son of a 94-year-old mother with advanced stage Alzheimer's, so I have a keen personal interest in that disease. And as a former football player with a relatively clear head, but a history of concussions, I have a personal interest in CTE as well. But will you talk about some of the really exciting research that's going on at UTMB in neuroscience and neurodegenerative disease? Because if you don't, I will.
Well, thank you. You know, it's always fun to talk about great work, and this is an exciting time, and I think all of us in the health institutions across the UT system are enjoying a tremendous improvement in our capabilities to really understand what's happening with the neurodegenerative diseases. It's a complex set of diseases. We know that the structural and functional changes that occur in patients who develop symptoms of Alzheimer's dementia actually vary from patient to patient. And so that's why we really haven't been able to find that silver bullet that we can use to stop those diseases, to stop their progression, the development of symptoms. But we're making great progress. And so we're understanding more every day about the different things that seem to predispose the development of those particular changes, those symptoms, looking at ways to combat them. We're using information more effectively. So again, it's an exciting time, not only at UTMB, but across all the University of Texas health institutions which have an interest in neuroscience.
Brain research is really only a part of what you're doing at UTMB. There is the National Science Foundation's Antarctic program. You are working with the Brazilian Ministry of Health to develop a vaccine for Zika. I mean, these are global reach projects, partnerships that you're involved with from a little island just off the coast of Texas. Talk to us about some of these projects and partnerships.
Yeah, you know, when Stone visited us last year, he asked the question, how in the world do you do this from such a remote location? And I thought, you know, the response that I should have created at the time was that, yeah, for those of us who live in paradise, Houston and the rest of Texas can be quite remote. But you know, I think one of the things that the people in this room well understand is the power of philanthropy. UTMB owes its start to philanthropy, the philanthropy of the Seeley family, yes, which has continued through this day from contributions from the Seeley and Smith Foundation. With the initial investment of the Seeley family, the John Seeley Hospital was built. It became the teaching hospital. That enabled UTMB to attract 13 original faculty members from all around the world. Great medical educators, great physicians, great scientists, and they began the legacy of service that continues to this day. It's always about the people in terms of the work that's done, the contributions that are made, the recognition that comes. But were it not for the power of philanthropy, it wouldn't be happening at UTMB.
Talk to us a little bit about the Galveston National Laboratory. It was mentioned in the video. I mean, you can't miss it on campus. It's that huge building with no windows. But this is the first level 4 biocontainment laboratory to be located on an academic campus. And when you really think about biological threats, whether it's disease or whether it's a weapon, this lab is critical to our response and our preparedness. Can you talk a little bit about it? I mean, when the next infectious disease strikes somewhere in the world, what does that mean UTMB's role is going to be?
Well, it's an amazing resource, and we're very fortunate to have it on our campus with such an incredible group of people as constitute the National Laboratory with all of its capabilities. UTMB would be expected to play a leading role in beginning a response. So that might include characterization, identification of a new virus or whatever the infectious agent is that's causing the problem, the development, rapid development of models to test transmission, propagation, new approaches to vaccines and treatments, rapid diagnostic tool development. Another role that we play actually is in providing information support to local responders who are not only dealing with ill patients, but also the patient or the population that's very worried about becoming infected. So we do a lot of education and training in support of efforts against infectious disease around the world. Really great thing is this is work that occurs every day in the Galveston National Laboratory. So if such a threat emerges, it's not a matter of beginning a de novo effort. It's really just a matter of shifting focus to provide that leadership.
Dr. Calhoun, let me ask you, UT Health Northeast started as a tuberculosis sanitarium back in 1947. And I know you've come a long way, but your institution is still one of the top institutions in the country for lung disease treatment. Talk a little bit about how and why your institution is going to continue with its diagnosis and treatment of lung diseases.
Yeah. Thank you, Stone. It's a pleasure to be here with you and with my dear friend and colleague from Galveston. My career in Texas started in Galveston at UTMB, and so it will always have a special place in my heart. Tuberculosis has plagued mankind for a millennia, and our ability to treat it for a very long time was quite limited. And so the way it was mainly dealt with, and some folks in here will remember this, is that patients were contagious and they were sent off to TB sanitariums to be treated. And that treatment at that time, in many cases, took years. And some people never left the tuberculosis sanitarium. Our present campus was the principal tuberculosis sanitarium for the state of Texas. What I didn't realize until I got there was that it was started in 1947, and at that time, healthcare in Texas was segregated. And so our campus was the tuberculosis sanitarium for African Americans. That was meaningful because I grew up on the south side of Chicago, and I had an uncle who had tuberculosis, and I would go and visit him in the sanitarium and see him there. Eventually, segregation fortunately went away, and it operated as the principal TB sanitarium for the state until through the late 50s and 60s, and in part through the work that was done on our campus, we came up with better treatments for tuberculosis, and the sanitariums around the country either closed or they morphed into something else. And the something else for us through legislative action was that in 1978, our campus became part of the UT system and the great health enterprise that is the UT system. Since that's our history, we still continue in that realm. We don't necessarily have a bunch of TB patients on our campus. We actually have very few. But we do work in a facility, a state facility here in Texas. And we run tuberculosis programs for 9 states across the middle of the country under a contract with the Center for Disease Control. We continue to do quite a bit of research, international research in tuberculosis. I have people that are in India and other countries around the world. We're challenged with what's called multiple drug-resistant tuberculosis. And that's something that's present in the United States and requires very specialized treatment. And we have experts in how to deal with that. Tuberculosis is a disease typically of poor people, people of lower socioeconomic status. But there's a cousin to Mycobacterium tuberculosis. It's called Mycobacterium avium. Some people say the avium complex. Its nickname is MAC. And it has a predilection, surprisingly, for wealthy white women. And there are only a couple of places that have national reputation in dealing with MAC, National Jewish in Denver, and the other is UT Health Northeast in Tyler, Texas, talking about being remote. I can beat you at being remote, David.
Wow. So once the segregated sanitarium for African Americans in Texas
care of wealthy white women from all over the world. Yeah, that's good. And we have a library of the various isolates of this particular disease and people who have dedicated their careers to fighting that disorder. But, you know, we're facing some new challenges in Northeast Texas, and our campus has evolved quite a bit from that tuberculosis sanitarium, eventually to a chest center, and now a regional academic medical center.
Well, I know that Texas really is already struggling with a severe shortage of physicians, and that is particularly true in rural areas. You serve a lot of rural areas in Northeast Texas. What are you doing to address that problem?
Well, that too is a very good question. We know we're going to be facing a shortage of physicians. But even more important than the shortage is a maldistribution of physicians. And doctors are like anyone else. They tend to want to live in urban areas with, you know, all the benefits that come with being in an urban area. They like to practice at large medical centers that can afford to make accessible to them the latest technology, the most advanced kinds of things. And so getting physicians to choose to go practice in rural communities is a real challenge. Our training programs, our graduate medical education programs have all been focused on primary care, internal medicine, family medicine, occupational medicine. We're starting a psychiatry training program. And what we do as part of our culture on our campus is really make being a rural doctor an attractive thing to do. We put serving rural communities up on a pedestal and try to convince our graduates that when they finish their training programs, that they want to go to communities like Tyler and smaller communities and have a real impact. One of the issues is that if you go to a rural community, that primary care physician frequently becomes the public health officer who has to deal with outbreaks of epidemics and so on and so forth. So we've really stepped up the training in public health for our primary care physicians so that they do have the skill set to go to these smaller communities, be successful in their practice, and help elevate the health care that occurs in those communities.
About 2 years ago, you hired Dr. David Lakey, the former Texas Health Commissioner, and I understand he holds a joint position with UT Health Northeast and the UT system as an Associate Vice Chancellor for Population Health. That's a relatively new term. What is population health and why is it a priority for the UT system?
You know, it was a real thrill because Dr. Lakey was my chief of infectious disease in Tyler. And when he was approached by Governor Perry to become the chief medical officer for the state, I really thought it was something special that when they had to find someone to take on that role, they turned to our campus and took one of our own to go and do it. And as Health Commissioner of Texas, David did a fabulous job. I've actually thought a lot about population health. It's a big topic right now for the health component presidents, health institution presidents of the UT system. And it's difficult to explain because there are probably so many definitions. But it has some core elements. One is health outcomes and impacting health outcomes. It's determinants of health. What factors influence health? And we talk a lot about the social determinants of health. It's developing policy and interventions that will improve the health of a specific population. Population health is a big part of this in that you're dealing with a special population that can be geographic, it can be employees, it can be members of a health plan.
So it's targeting specific
It's targeting specific populations, as I said, geographic, whatever, and using those elements of outcomes and determinants and policy and interventions to impact care. Now, so the audience understands it a little bit better. I want to just give them a scenario, and I do this with my students. There's individual health care. That's what we do in the United States right now. A lot of individual health care that's sort of focused on you. And you come see me as a patient in Tyler. And I will do a physical and I will take a careful history. And you will tell me that you smoke. And as your doctor, I will advise you not to smoke because it can cause lung cancer, it can cause COPD, it can cause cardiovascular disease, and you'll get sick. And I will do everything I can to save you, and I will spend hundreds and hundreds of thousands of dollars, if not millions, to keep you alive and help get you through that disorder. Or I can do population health. I can look at all of Northeast Texas, which our academic medical center, so it feels responsible for Northeast Texas. And I can look at our poor health outcomes, which we have. Our county health outcomes are very poor. I can look at the fact that there are too many hospitalizations, that the hospitalizations take too long, and that the costs are too high for providing care in our region. And I can ask the question, what's causing that? And I will discover that we have a high rate of lung cancer, we have a high rate of chronic obstructive pulmonary disease in our region of the state, and that coincides with the fact that we have the highest tobacco use, the highest cigarette smoking in the state. And so from a population health point of view, now I am challenged with how do I improve health outcomes? By attacking the fact that my region uses tobacco too much. There's too much smoking. And what interventions work? We know that certain social interventions work. We know that the better educated you are. We have Dr. Tidwell here, who runs the academic campus in Tyler. We know the better educated you are, the less likely you'll smoke. We know that the more income you make, the less likely you'll smoke. We know the higher social economic status you have, the less likely you'll smoke. And we know that if we ban smoking in public places, and if we make through taxation, the cost of cigarettes too expensive for young people to buy them and start smoking in the first place, we can dramatically lower smoking. What has the least effect on smoking? Your doctor sitting in front of you and saying, you need to stop smoking. That's the difference between population health and individual health.
Even less credibility than the doctor is the member of the media who tells you that. One of the linchpins of Chancellor McCraven's quantum leaps is collaboration with other institutions within the UT system or with institutions outside. And we talked a little bit about collaborating with the Brazilian Health Ministry, David, to come up with a vaccine for Zika. Can you talk about how important collaboration is when it comes to healthcare, whether it's on the research side or whether it's on delivering clinical care?
Well, absolutely critical. And I think the UT Health institutions are collaborating more effectively today than we ever have in the past, and that's a good thing. Some people believe that competition among us is also good to some extent. I think the most important competition we have is to improve our current state, to move to a place that's better. There's a quote by Ernest Hemingway that I really love, and it goes something like, "There's nothing noble about being superior to your fellow man. True nobility is being superior to your former self." And so that's what we're trying to do as a group of UT Health institutions and generally as a UT system. We have actually great complementarity. We all have areas of excellence, such as pulmonary disease, infectious disease, brain health, and the like. Collaboration is messy and time-consuming, but it's absolutely essential if we're going to solve some of these very complex problems. And so what we're trying to do is to come together to define the problems more specifically, define the specific things that we bring to the table as an institution and as a group of institutions, work with our senior leadership to overcome the parochialism that's natural among institutions like ours, think about how we more effectively use data and adapt to data, particularly in real time. Understand that we're responsible and accountable as contributing organizations for reporting our results back, our current outcomes back to the entire group. And where we really have an advantage as a UT system is the system is the strong backbone. It makes sure that the work continues, that we all are accountable, that we're doing our part, and it takes the broader view to help us move forward together. So with such a strong backbone, we have the opportunity to get over the time-consuming nature of collaboration and the messiness that's associated with it, and that's definitely in our favor.
Critically important. Gentlemen, thank you both. Your institutions are Texas treasures, and we really value and appreciate your leadership. Thank you both.